Hello, are we there?
مرحبا يا بروف. صور واضحة والكلام واضح.
Shall we start? عزة مرسي مجدي دعاء. Shall we start? Are we there? أنا عثمان عبدان.
Yes, Prof.
You are okay?
Yes, إن شاء الله نبدأ طوال.
Okay. Bismillah ar-Rahman ar-Rahim. It's a pleasure having you back on this Sunday lecture, which comes 1 hour later than last time. But I think we will have a good discussion about infective diarrhea. We remember we talked about microbes in general, and the microbes are living around us, living within us, living on us. Okay, they are very important in our life because they complete the cycle of living, and they boost the immunity, the host immunity of our immunity, and they provide, when they inhabit the colon, they provide a lot of nutrients, which are important, and they overcome, paradoxically, the pathogenic bacteria. So they do double job, killing the other bacteria, providing nutrients, and providing immunity to the patients. So if we wanted to talk about microbes and gastroenteritis last time, you remember, we started talking about enteritis. And enteritis is, by definition, inflammation, infective inflammation, usually by bacteria of the gastrointestinal tract, oral to mouth to anus, with the exception of the stomach, because the stomach has this hydrochloric acid, which kills almost 99% of the bacteria that comes in. Okay, some of it hide behind, some of it has encapsulation, and some of it survive the living of hydrochloric acid, like Helicobacter, but the helix, the helical or helix-like Helicobacter pylori. But gastroenteritis is a very known disease, spread all over the world, and it is recognized as Shigella species, or Shigella shiga, or Shigella sonii, are the most common infection of gastrointestinal tract, and maybe overall. So what results from the gastrointestinal tract is enteritis or gastroenteritis. Everybody who goes to the outpatient of the children department or children hospitals, they will see at least 1/3 of the patients are with gastroenteritis. So what is the fear from gastroenteritis? Apart from, diarrhea and vomiting, which is not nice, but we fear the dehydration. The dehydration. And dehydration is not a sign which will affect children, but also adults. So if a patient comes with loss of 8 to 10% of his or her weight, still he is under hydrated, but not severely dehydrated. So if it goes beyond 10%, the eyes become sunken, and the skin turgor becomes inelastic, okay, and the tongue becomes dry, and the eyes sunken, and the tears disappear, okay, and then goes down, the abdomen will be scaphoid, and the skin all over become dry. But the patient is restless, and this is a good sign, in a paradoxical way. This is a good sign, because if you are restless, you still demand water. So the patient is thirsty. Okay, if he is given water, he just drinks it like very quickly. And then if this is not corrected, this is a stage where you should give oral rehydration salts. But if this is continued, then you will have what we call severe dehydration with severely sunken eyes, very dry tongue like a wood, like wood. The skin loses all texture, and if you pull it like that, it stands like that. The patient anus have a big pain, because of the repeated motions. But most important is that the patient turns from being restless and irritable into a patient who is drowsy and may go into coma. So this is what we fear from severe diarrhea or diarrhea which is not controllable. So please always remember, even before knowing the diagnosis, what is the cause of the gastroenteritis? Replace the fluid. Replace the fluid with oral. And sometimes the argument is if the patient is vomiting, why should I give him because he's going to vomit it? No. Some of it will be retained. And the assuring phenomena is that even in cholera, the absorption of sodium and glucose is almost normal. So with that, I think we are encouraged to give oral rehydration fluid. That is the one thing which is I want to stress and over stress. Okay, this lecture we're going to start it with the case, which I hope everybody had time to read it, and I will go through it. This is a 21-year-old student who is traveling in South Sudan and is staying in guest houses. No information given in the case history, which is redundant. Always try to say the examiner, what does he have in mind? What does he have in mind? But when he says student, then it's young, vigorous, wanted to go around and staying in guest houses. So the food which she's taking is not that, high quality and may eat from the streets. And if you eat from the streets, then you expose yourself to flies and expose yourself to people who are food handlers because they don't use gloves. And these food handlers in many countries, especially tropical countries, have a lot of, they are carriers of a lot of diseases, okay? And this is very dangerous because if they can disseminate the infection very rapidly into the food. So this lady or this girl stays developed fever, chills, and generalized body aches and pains. Okay, the first thing which comes to mind is malaria, and you are right. If you come with that, one would think of the fever and chills, especially chills, and the generalized body aches and pains, okay, as malaria. But see what is happening. The next day, she was anorexic, she lost appetite, and developed acute watery diarrhea. Still, in malaria, we can have watery diarrhea, but 12 hours later, she had a severe gripping abdominal pain, okay, which is in contradistinction with malaria. Malaria will give discomfort, okay, but this is gripping pain. Gripping pain is like colicky pain, okay, and we will come to the terminology in a minute, which is appropriate to this gripping pain, okay. And the site is left lower quadrant, okay, almost on the area of the sigmoid and rectum, okay. Then the disease changed, and then the lady started to change from diarrhea into small volume stools, Now we are getting into the proper diagnosis. With the exacerbation of pain, so she gets sense of defecation, she gets abdominal pain, and then things becomes more painful. Okay, now it's progressing to feel that there is blood blood-stained motion, and the motion is uniformly stained by blood, and then she has this sensation of wanting to empty the rectum. So this is what we call abdominal grip, okay, abdominal colic, with a sensation of wanting to go to the toilet. You wanted to empty the rectum. And the urge, okay, عسرة اسمها بالعربي عسرة اللي هي tenesmus. This is important word which indicates that not only you have abdominal pain, but with it that the bowel moves and you want to go. But when you go, you only pass a little or a small amount of feces. Okay. And dysentery, this description hello, hello.
يا بروف صوتك واضح.
Okay. قطع الصوت قال هوت ولا شنو ما تعرف.
اه
Anyway, we will continue now with this case, and we talked about tenesmus. Then she had temperature 38.4, a low blood pressure 90/60, meaning that she lost fluid, and there is tenderness in the right lower over the lower quadrant of the abdomen, and she passed this blood in the stool. So dysentery is by definition an old term which is diarrhea with blood. It has to be with mucus and then with abdominal pain. And since Hippocrates, Abu Qurat, he gave this description of dysentery. And you remember we've been talking about dysentery and the cause of dysentery. But here, as far as this case is concerned, this is most probably bacillary dysentery or Shigella dysentery, which is a bacteria, which is a small rod, gram-negative bacteria, and it's very infectious. Infectious meaning that you don't need a big dose of bacteria to contract the disease. So it is the most infectious, meaning that if you have a few hundred bacteria in your hand, then you can pass it man to man. There are no animals in between. So it is very important in the hygiene. Okay, washing hands, examining the handlers of food, and the rest of it because of this Shigella. The important thing, it's an acute disease. Acute disease. This girl was very good. Suddenly she had this diarrhea, and then even if you leave it without treatment for a few days, then it may settle or becomes chronic, which is in contradistinction to amoebic dysentery. Amoebic dysentery is caused by Entamoeba histolytica. So the differential diagnosis here is of an acute infective diarrhea, which is shigellosis. It could be salmonellosis, okay, of the type, Salmonella typhimurium, which is contracted by rotten or spoiled eggs. This is a toxin which gives you diarrhea and dysentery. Or Campylobacter jejuni. This very, very much gives the same picture. Or invasive E. coli. This E. coli is very intriguing bacteria. It can live as commensal without any harm to us, but it has characteristic of being invasive. It can produce toxin, what we call enterotoxins, enteropathic, enterohemorrhagic, okay, and it can cause diarrhea, very much similar to Shigella, okay. And in a matter of fact, it shares with Shigella bacteria, it shares an antigen, meaning that it can give a picture very similar to this. Okay, uh, why is it not amoebic? Amoebic is usually starts insidiously and gradually progressive. Okay, so it's most probably shigellosis, or the invasive type of Shigella or Shigella dysentery. Okay, when we examine the stools in shigellosis or Shigella dysentery or bacillary, what we call bacillary dysentery, we find, small amount of fluid of feces. It contains pus cells, which mean invasive bacteria, and then the RBC is there and the blood is there. It has a nasty smell. So it is very quickly responsive to treatment. And here we have to talk about resistance, because in many countries now it is being resistant to some of the bacteria. We used to give cotrimoxazole before, which used to respond tetracycline, but these drugs are no longer in use because resistance has developed, and fluoroquinolones derivative, fluoroquinolone derivative, or ciprofloxacin. These are the drug of choice nowadays for Shigella dysentery. So, what are the other causes? Remind us of the other causes of dysentery. Uh, we can talk about them. Majorly is amoebic dysentery, which we'll come to it, and then Campylobacter, and then the protozoan, which is amoebic, or it could even be Trichinella spiralis, which is Hillman's, and dysentery of schistosomiasis, again acute dysentery, can be caused by schistosomiasis, Mansoni, and the shigellosis, which is Shigella, or Salmonella, Salmonellosis, which is of three types. Salmonellosis, Typhimurium, Salmonella typhi, and Salmonella paratyphi. Okay. And then we can talk about viral that causes dysentery or gastroenteritis. These are rotavirus, which is now very common and can be vaccinated against, adenovirus, and enterovirus. So it is rotavirus, adenovirus, and enterovirus. All this will give you the diarrhea and maybe dysenteric diarrhea. Okay, Cardia lamblia is another confusing parasite. Okay, it's usually it lives as a commensal. Okay, but it can be invasive and cause severe diarrhea. Okay, so it is important to remember, okay, that the treatment is different. Treatment, while in viral infection, is mainly replacement of fluids, and the other things is, specific treatment only for the antibiotics, which is for the diarrhea due to bacterial infection. Okay, bacillary dysentery, you remember, is a small gram-negative rod. I'm repeating this. It is a small gram negative rod from the family of Enterobacteriaceae. Okay, and we said quinolones are now the drug of choice. Up to now, there is no vaccine, but it is in development. And we said that the differential diagnosis is invasive E. coli. Is invasive E. coli, and it shares an antigen with the E. coli. Okay, the second most significant in line comes second to bacillus disease is amoebic dysentery. In amoebic dysentery, this is Entamoeba histolytica. You remember that there is Entamoeba coli. This is commensal, but Entamoeba histolytica can be invasive. There are two types of Entamoeba forms. The one is the capsule form, and the one is the invasive Entamoeba active form, all right, or what we call vegetative form. And this vegetative form can be characterized from Entamoeba coli by the presence of RBCs within the Entamoeba. And this is again a disease which is common and it causes dysentery, which is of insidious onset. Okay. The other form is the cyst form. And in the cyst form, people can pass cyst. Very rarely these cyst carriers can develop Entamoeba active, but they pass it to other people who are vulnerable, and the cyst will get encysted, or the cyst will come out, and then it goes in the intestine, colon, and then invades and causes acute amoebic diarrhea. There are two types. You have amoebic diarrhea, which is common, and in amoebic diarrhea, it's just like abdominal pain, vague discomfort, and then watery diarrhea, almost watery diarrhea. And this is very common. It's more common than the second one, which is dysenteric amoebic diarrhea. Okay, there is no blood. Usually there is no blood and no mucus. And then we have the amoebic dysentery, which is very similar to dysentery due to bacilli of Shigella. And here, abdominal pain. You can always have fever, and passing stools. Usually, the amount of stools which is passed by amoebic dysentery is more than bacillary. And you may get a question about how to differentiate the Shigella, bacillary dysentery, and amoebic dysentery. One of them is the stools with Shigella, bacillary dysentery, small amount. A lot of it is mucus, RBCs, uniformly blood. In amoebic dysentery, although it has the same character, diarrhea is more fluid, and the stool's content and volume is higher, okay, and less of blood. But the other abdominal pain, less tenesmus in amoebic dysentery. One complication of amoebic dysentery is amoebic liver abscess. And amoebic liver abscess, this is an important complication of vegetative form. There is no cyst in the liver, only the vegetative form, which is the active form. And this cyst usually is in the liver, right or left. And the patient presents with fever, abdominal pain, particularly in the right hypochondrium, and enlarged liver and tender liver, and there is intercostal tenderness. This is an important sign which we used when amoebic liver abscess was common. This is an important sign. And if it touches the diaphragm, the right diaphragm, then pleural effusion can occur. So this is an important aspect of a complication of amoebic colitis, amoebic liver abscess. And luckily in Sudan, now it is less and less common. And I think even amoebiasis, or the active form of amoebic colitis, is rare and less because of the raised hygiene. Now food handlers are being tackled and examined regularly. Three in my reckoning, it is the use of metronidazole. The metronidazole, which is very good in amoebiasis, is a drug of choice of luminal amoebiasis or colitis, and it is useful also in liver abscess of due to the amoeba. Okay, the use of metronidazole, unfortunately, but it serves the cause of the amoeba, is that it is now being used haphazardly without reason. Everybody is now being given metronidazole. It's over the counter. Patients, if they have abdominal pain, just light abdominal pain, they say we have Diarrhea, okay? And they go to the chemist or the pharmacist, they get metronidazole. And this is, even if it's amoeba, it is being treated early on rather than chronically established. So this is one of the causes of the why we don't find a lot of amoebic dysentery. You need a big dose of amoeba to cause amoebic colitis. Okay. So what are the common causes we said about colitis? Because I want to introduce another cause which is non-infective. Okay, we already said the dysentery, Shigella, Salmonella of all types, Campylobacter. Campylobacter is C-A-M-P, C-A-M-P-Y, Campylobacter, B-A-C-T-E-R. This is Campylobacter jejuni. This gives very much like Shigella. So we have also Clostridium and botulinum, Staphylococcus botulinum, which produce botulinum toxin, okay, and which causes nervous system paralysis. This is again will give diarrhea. The viruses which you already mentioned is rota virus, adeno virus, enterovirus, Amoeba histolytica, that is a protozoan, giardiasis, active giardiasis. But what we see, the giardia in the stools, which is often reported on by the technicians, then these are commensals. They are not the cause. So unless you have very good reason to think that this giardia is causing the diarrhea. Okay? So, what is the use of botulinum toxin? Now, it's talked about as Botox. And cosmetologists now are using Botox to straighten the skin. Okay, it is used also to relax Achilles tendons in patients with cerebral palsy. Okay, because they have the spasticity and they can't walk with ease, so they are being injected with botulinum toxin in the tendon Achilles or in the muscles, and this will relax the muscles for a few months. But the very fashionable now they use botulinum toxin in the cosmetics of straightening the skin because it and then the change which can occur in the face. You know, if you have a dump here, then you use botulinum toxin or threads or injections of material. Okay, what we call filler. But botulinum toxin is one of the good reasons. Okay, if Arwa there, you can see some of the pictures or photos which we have prepared. One of them is the amoebic abscess. This is Arwa. The revolution in the diagnosis of amoebic liver abscess is, the introduction of ultrasound, because years gone, we didn't have a very good method of seeing the cyst, okay, seeing the cyst. But with ultrasound, this is an ultrasound, and I would like you to see this black structure, which is here and here. Okay, fluid in ultrasound will look black. Fibrous tissue will look echogenic, which is white. Echogenic meaning it reflects the echo or the sound. The black is translucent, meaning that the fluid will not reflect the wave, will not reflect the sound. So it appears black. So, and this is another one in the left lobe. These are the amoebic liver abscess as seen by the ultrasound. The beauty of it, we can see it now. We can even direct it. We can aspirate the abscess by ultrasound guided methods. Okay, next. It's not moving. Uh, yes. Then this is here. Thank you. This is here is the abscess, the amoebic liver abscess. Okay, and you can see how nasty it looks. Even the walls is ragged. All right, this is amoebic liver abscess. But as we said in other lectures, the liver has the capacity of regenerating. Okay, has the capacity of regenerating. Okay, next, we would like now to see the active or vegetative form of, yes, this is the active or vegetative form of the entamoeba. This is the entamoeba cyst, okay, and you can see the cyst around here, and this is, quite benign in a sense that it doesn't cause any symptoms or dysentery. But if it is encysted and opens up, then it can produce the active Entamoeba histolytica, which contains blood. I think there is another picture, if you can get it, of the Entamoeba histolytica containing the RBCs, which really differentiated. Yes, this is the one. Entamoeba is single cell, and inside you can see the RBCs, which differentiated from Entamoeba coli. So, in summary, that dysentery is important disease, common gastroenteritis causes dehydration. Treatment is now very easy, and we achieve cure. We fear from the carriers, and this is not only for entamoeba but for all other infections, because these they could be within us, the Gardaí within us, but it becomes invasive, it causes diarrhea. Entamoeba cyst, it can be passed unnoticed by carriers, but once it insists or open the cyst, then it becomes invasive. Okay, the important thing is what are the causes of dysenteries, and you should remember that there are other causes of diarrhea with blood, what we call ulcerative colitis. You know it very well, which is the distal colon, all right, to the transverse colon. You get severe ulcerations, and this is an entity by itself, but it can give symptomatology and signs like this infective dysentery. Okay, and there is what you call pseudomembranous colitis, which occurs with drugs, and it is caused by a bacteria, which could be a commensal called Clostridium, but once it becomes invasive, we know it as Clostridium difficile, difficile Difficile, difficile, okay, causing very typical picture of the natural occurring ulcerative colitis. It is caused by antibiotics. Okay, it's particularly clindamycin. I think with that, I would like to conclude, and we hope to see you next time. And we would like to thank Arwa, who has been with us showing the slides. Thank you. And for batch 26, Dina has already arranged, I hope, with Ali Abdelal, who is a physician, cardiologist, and acute medicine. He's going to give lectures on medicine. We already talked to Nuha Mamoon, who is a radiologist, now consultant radiologist, who is very willing to give X-ray sessions on whatever you like. She's an expert in and ultrasound and imaging, CT and MRI on children, but can give general radiology sessions. With that, thank you very much indeed for being with me in this lecture.